Okay, in this next section, we'll focus on the biomechanics and kinematics of spinal manipulation for each of the spinal regions in turn, specifically the cervical, thoracic, and lumbar spine regions. This specific presentation will focus on the fourth bullet point that you see here, the biomechanics of spinal HVLAT. And we'll start by discussing the arthokinematics of the human spine and at each of the different levels, cervical, thoracic, lumbar, and the overall concept of coupled motions. The arthokinematics of the human spine. Okay, we'll start with the cervical spine. We'll start with extension as the first movement. According to Newman, the arthokinematics are described with the superior vertebra moving along the inferior vertebra. If you look at the small image there, A, where you have the OA joint, there's going to be a ipsilateral roll in the same direction as extension with a slide of the condyle anteriorly. When we're looking at the AA joint complex, there's going to be a ipsilateral tilt, and then for the what we'll classify as the lower cervical spine, though it says C2 through C7, typically the lower cervical spine is considered C3 and below, that you'll see that you have a ipsilateral sliding effect of the facets as the individual goes into extension. So it's ipsilateral to the physiological motion of extension. Okay, considering the opposite motion of flexion, once again, we'll look at the OA joint, the AA joint, and the intracervical regions of C2 through C7. So at the OA joint, there's going to be a roll in the same direction as the motion. So the condyle is going to roll anteriorly while it slides along the atlas posteriorly. In the B figure, you can see that there's an ipsilateral tilt of the atlas to the axis. And then the intracervical region, C2 through C7, has that same ipsilateral component where the sliding of one facet on the next is in the same motion as the physiological motion. And it's going to be a superior slide bilaterally. When looking at cervical rotation, Newman breaks this up into the AA joint as half or up to 40 degrees of the rotation comes from this joint, and then once again into the intra-regional segments of the cervical spine. So the AA joint, you can see that there's a slide of the, if we're talking about the ipsilateral facet, so if you're going to turn to your right, we're looking at the right facet. There's going to be a posterior slide on that side with a contralateral anterior slide on the opposite. And so it's going to be almost like a pivoting around the dens. And that blue dot on the dens denotes the center of rotation of the atlas on the axis. When considering C2 through C7, we can see that there's going to be an opposing direction of the slide, similar to the AA joint, so that as you look to your right, the facets on the right side of the cervical spine will slide down and back, while the contralateral facets, the ones on the left side, will slide up and forward. Okay, still on rotation, when we look at the mid-cervical spine, we can see that there's approximately a 45-degree inclination of the articular facets. This dictates the spinal coupling movements in the frontal and horizontal planes, specifically with rotation and side bending. Superior vertebra facets follows the plane of the inferior vertebra facets. For clarity on this, an example would be C4 and C3. So if we focus our attention on the right facets of C4 and C3, the angulation of C4's facets will dictate how the C3 facet moves along that plane. that's essentially what the bullet point there is describing. So the motion will be determined by the inferior facet angulation or inclination. Lateral flexion and rotation in an ipsilateral fashion, meaning that as I rotate to my right, there's going to be ipsilateral side bending to that side, with the exception of the C0 through 2 region, so the upper cervical spine. There's actually a counter rotation, and this is really to keep the orientation and maintain visual orientation. So for instance, if you were to pause the video and side bend your head to the right, then it's possible that your upper cervical spine will rotate to the left as a means of keeping your orientation looking forward. Depends on, of course, where you're focusing your vision and where you're orienting yourself to. And then it also should be noted that the coupling patterns are not so apparent with visual observation, particularly of the upper cervical spine. But when you look at this with 3D and 2D kinematics, there's consistent agreement with this, with the lower cervical spine, lateral flexion and rotation to the same side, and then some more inconsistencies with the upper cervical spine, presumably depending on how the individual is orienting themselves and where their attention and focus is. Okay, it's important as we go through this to have some nomenclature and some context for coupling motions. So according to osteopathic convention, there's 2 types of movements here, right? So type 1 movement is side bending and rotation occurring to the opposite sides, right? So that's opposite of what we just said in the cervical spine. And consistently, at least myself, I need to continue to come back to the coupled motions because I continue to get kind of turned around by them. So type 1, they're occurring in the opposite. Sometimes I think of numeral 1 as being odd, and that's opposite, and I associate those two. And then there's type 2 movements where it's even, and so they occur in the same motion, and that's one of the ways that it's helpful for me to remember it. So when we use this coupled motion in the cervical spine, as we talked about in the last slide, so the mid and lower cervical spine will move with a type 2 coupled motion, whereas the upper cervical spine, if we're going to counter rotate to keep our orientation, is going to be a type 1 movement or coupled motion. Okay, it's hard not to talk about coupled motions without talking about Freyettes Laws. So he has 3 of them. So law 1, a neutral spine. If the spine is in otherwise stacked or neutral position, then side bending produces rotation to the opposite side, which is our type 1 coupled motions that we discussed in the last slide as defined by the osteopaths. Or in other words, the side bending group rotates itself towards the convexity of the side bend with maximal rotation at the apex. Freyette does not specify what region of the spine he's using his laws for. Presumably, this is for all regions. Okay. Law 2, non-neutral, either hyperflexed or hyperextended rotation and side bending go to the same side. So if you're not in your neutral position, then the spine will be demonstrating a type 2 coupled motion pattern. Individual joints act at one time. Law 3, introducing motion to a vertebral joint in one plane automatically reduces its mobility in the other 2 planes. This is going to be important when we talk about joint locking mechanisms, and even in the initial videos that were sent out, you could see on the fluoroscopy, as Gibbons and Tejan had described, the locking mechanisms with the coupled motions of both the cervical and the lumbar spines. So coupling motion research in general, some conclusions that can be made. The majority of them are cadaver research. Allows for precise measurements to be taken of coupling behaviors, but unable to reflect the activity of muscles or the accurate effects of the loading on different postures. And obviously there's not going to be any orientation or counter rotations within the cadaver models. 3D computed tomography, digital video fluoroscopy, and MRIs are considered the gold standards when it comes to coupled motions. Reviews of the literature conclude that coupled motions exist, but there is conflicting evidence as to the specific characteristics of the coupled motions. Okay. Excusing that digression on coupled motions, we'll go back to the upper cervical spine, and we're looking at side bend. And so the craniocervical region counter rotation to maintain the orientation as previously discussed. And you can see that it's looks very similar to the arthokinematics that we saw within the rotation of the cervical spine. The exception here is that the emphasis is on the OA joint, and then the intra-cervical regions of C2 through C7 versus the AA joint. And the purpose for this is that the majority of the side bend in the upper cervical spines comes from C0, C1. And so there's going to be a ipsilateral roll and a contralateral slide of the condyles as the individual rotates to their right. And so there's also been described the mnemonic of MIA and lips. So we'll talk about that now. So MIA stands for medial, inferior, and anterior movements of one condyle on the atlas. So as I rotate, or sorry, as I side bend to the right, then the right condyle will move inferior medially and slightly anteriorly, whereas the left condyle, as I side bend to my right, will go in a lateral, posterior, and superior motion. And so there's going to be actually kind of a triplanar movement here of the condyle on the facet of the atlas. And so though the picture denotes this kind of pure frontal plane movement, it's important to note that there is small three-dimensional movements of the condyle on the facet of the atlas. And then the intracervical regions, very similar to rotation, you're going to get a down and back motion of the ipsilateral facets with a up and forward sliding on the contralateral facets. Okay, so it's also important to consider, how do these arthokinematics of the joints change in the presence of pathology? So here's a study that was done. You can see the study design there. Kinematics of the cervical spine during head rotation was investigated using a 3D MRI in patients with cervical spondylosis. So you had 10 volunteers as a control group that were quote unquote healthy within their cervical spine, and then you had 15 individuals with cervical spondylosis. And what you can see in the results shown in table 3 there, so you have each of the different regions of the cervical spine broken out into upper, middle, and lower. You have the main motion, the coupled motion that occurred with lateral bending, and then the coupled motion that occurred with flexion and extension. So N denotes no marked difference between the groups, and then you'll see that the increase and decrease are denoted there. So the for the group with cervical spondylosis, when they left side bend, there's going to be increased coupled motion. So there's going to be increased rotation as they go through that side bend. However, if there's a lower cervical spine, there's going to be decreased motion. So, and not only with the coupled motion, but also with the overall motion of their ability to side bend. And if you step out of the context of the table for a moment and think about like what the results are actually indicating from a clinical standpoint, it actually makes a great deal of sense. So if we know that they're going to have decreased overall motion in the lower cervical spine, and particularly decreased coupled motion in that lower cervical spine, then the adjacent region, the middle, region of the cervical spine in the pathological group will actually take up the slack by increasing its coupled motion with that ipsilateral rotation. But flexion and extension are not otherwise changed. I also would like to premise that depending on the severity of the cervical spondylosis and the arthritis within the cervical spine, that at least in my clinical exposure, that extension and the ability for the down and back motion and sliding of the facets, be it bilateral or ipsilateral, has also been limited. But this is, again, dependent upon the severity of the condition. Okay, so another study that was done where I thought it was quite interesting, where they took 20 healthy individuals, 26 with cervical spondylosis, underwent a 3D CT of the cervical spine with maximal head rotation. And you can see that they actually use the 3D CT scan to formulate like an artificial model of the cervical spine. And so the results, same coupling patterns were observed in both healthy and spondylotic cervical spine subjects. Cervical spine patients showed a significant decrease in the movements of C4, C5 segment compared to healthy individuals. This is slightly different than the results than we saw on the previous slide, as far as the middle cervical spine being having a bit more motion. But again, we would potentially suspect that there would be maybe compensatory motions either above or below those segments where there's decreased motion, or there's going to be decreased overall motion for the spondylotic group. Okay, moving to the thoracic and the lumbar, we're going to lump these two segments together from the standpoint that Newman lumps them together, really from the standpoint that they have very similar kinematics, with the exception of rotation and side bending, which we'll get to, but the models will be the same for both. Starting with the thoracic region, you can see as I flex, there's going to be superior and anterior gliding of the superior facet on the vertebra, on the inferior facet of the adjacent vertebra. And the same is going to apply for the lumbar spine as well. The predominant difference is the plane of the facets, whereas the lumbar facets are, for the most part, in the sagittal plane, whereas the thoracic region, if we're talking about at least in the mid-thoracic spine, is going to be a bit more in the frontal plane relative to the lumbar. And then as you go down closer to the TL junction, you'll notice that the facet orientation of the thoracic spine will actually gradually mimic that of the lumbar spine as it comes into the frontal plane, or comes into the sagittal plane. Okay, and then this is one of the examples in which that slight change in the orientation of the facets would otherwise limit the overall capacity of the different regions to move. So for the thoracic region, there will certainly be extension, and there will be a down or an inferior slide and a posterior glide of the superior facet on the facet of the inferior vertebra, as shown with the model there in A. And then in the lumbar spine, you'll have that same kind of inferior and posterior sliding as the individual goes into extension. The thing to note here is that the longer protruding spinous process of the thoracic spine will block some of the available extension from the thoracic spine versus the lumbar spine. Okay, looking at rotation. So in that first figure A, we can see as the individual rotates to our right, then there's going to be a slide of both facets, regardless of the right or the left, to the left, with the again, the superior facet moving in relationship to the inferior facet. Then we have the lumbar region where because of the orientation of the facets, aligning a bit more in the sagittal plane as compared to that of the thoracic spine, where you can see that the facet orientation is much more in the frontal plane. There's going to be limited rotation coming out of the lumbar region. Okay, and when we talk about side bending, the thoracic spine is going to be predominantly limited in its ability to side bend due to the presence of the ribs. However, what motion that does occur when someone was to be side bending to their right, and we're looking at the mid cervical at T6, T7, we can see there's going to be on that ipsilateral facet, there will be a down and back slide. Whereas on the contralateral facet, there will be more of a superior slide, one on the other. And again, depending on what region you will that you're in and that you're looking at, there will be either more or less of a sagittal plane component to this, meaning it may be a pure, close to pure, more frontal plane motion. Okay, and talking about the coupled motions within the thoracic spine. So there's variability of the coupling of lateral flexion and axial rotation, most coupled ipsilateral. So this would be our type 2 form of coupling where they occur in the same region, but again, there is variability. In the upper thoracic segments, lateral bending was coupled with axial rotation in the same direction, again type 2 coupling, but in the middle and the lower thoracic segments, lateral bending occurred both in the same and opposite direction, so that there's going to be some variability here. Okay, so you can see that there's been several authors and research groups that have considered the lumbar spine coupled motions. We'll look at each one of them in particular and how they compare to Freyettes Laws of 1, 2, and 3, and label them accordingly to type 1 and type 2 coupled motions. So Paris and Lubert looked at contralateral rotation, so that would be type 1 coupling motions of side bending in the erect spine. This is consistent with Law 1 of Freyettes Laws, where he said that they would occur in opposite motions. Kaltenborn agrees with Freyette half the time, right? So then the difference here is that Freyette would say that if you're in a hyperextended or a hyperflex spine, then there's going to be ipsilateral or type 2 coupling. But Kaltenborn says that this only holds true in flexion versus when you're in an extended position, then it's going to be a the type 1 coupling will still persist. And this is consistent with van der El, who said mid-range extension would also demonstrate type 1 coupling. However, with the there will be ipsilateral coupled rotation with side bending and or rotation and flexion. So consistent with Kaltenborn. The one thing of note is that they said that if you go to your very end range of extension, then you may also get the ipsilateral extension. This would be somewhat more consistent with the Freyettes Law 1 and 2. Greenman, the contralateral rotation coupled to side bending in spinal neutral and extension. So this is consistent with Colton-Born. It's inconsistent with Freyettes, once again, because Freyettes said he would have expected in extension that the coupled motions would have been ipsilateral. And then ipsilateral rotation coupled with side bending and flexion. This is consistent with Colton-Born and van der Rohe. And then finally, Gatterman and Panzer, contralateral rotation coupled to side bending. They don't specify whether there is neutral, extension, flexion, etc. So this would be reiterating Freyettes' first law. Okay, so does the evidence support the existence of lumbar spine coupled motions? A critical review in JOSPT in 2007. And you can see that the number or percent of the studies and the subjects in each of the 5 coupled motion categories. And you can see the categories just orienting you to that first column. Type of coupled motions. For most subjects, side bending and rotation is coupled to the opposite side. For most subjects, side bending and rotation is coupled to the same side. So essentially you can put in type 1 coupling and then type 2 coupling. And then for most subjects, coupling varies depending on the spinal level. And then coupling between the side bending and rotation is inconsistent, so essentially equivocal. And then for most subjects, coupling between side bending and rotation is non-existent. So what you can draw from this, right, and we'll kind of go in the reverse order, is that there's between 6 and 7% of studies and subjects will have non-existent coupled motions. So there's over a 90% chance that coupled motions exist. It's just a matter of the variability of how they're occurring, whether they're type 1 or type 2. So coupled motion and side bending is inconsistent. On average, it's inconsistent between 28% of the studies and 23% of the subjects. For the most part, right, we can say that depending on now if we're talking not about the same level, but we're talking about adjacent levels of the spine, and that might be dependent. So it seems as though there may be discrepancies as far as type 1 or type 2 motions based upon the level that you're specifying. At least almost half of the subjects had this variability of coupled motions at different segments or different levels that were considered. And this was, of the percentages that you see, the most prevalent one. So it may, in fact, we can't just say, okay, for all lumbar spine vertebra, they follow this motion, this type 1 or type 2 motion in flexion or extension, but rather it actually may be determined based upon what level of the lumbar spine that we're discussing. Okay, in summary of the coupled motion discussion. Coupled motions occur in all regions of the spine. Coupled motions are independent of muscular activity, but muscular activity may influence the direction and the magnitude of the coupled motions. Coupling of the side bending and rotation in the thoracic and lumbar spine is variable in degree and direction, and apparently also by level, as denoted by that JOSPT study that we just looked at. Many variables can influence the degree and the direction of the coupled motions, and this includes pain, vertebral level, posture, facet tropism, and or even like the orientation gaze of the individual. There does not appear to be any simple and consistent relationship between the conjunction of rotation and intervertebral motion segment level in the thoracic and lumbar spine. The evidence in relationship to lumbar and thoracic spine coupling is inconsistent. Freyettes Laws hold true in relation to side bending and rotation coupling in the cervical spine. The evidence suggests that C0, C1, and C1, C2 axial rotation and lateral bending occur in the opposite sides, so they demonstrate type 1 coupling, versus the cervical segments demonstrate type 2 coupling in the same motion. And this has been presumed due to the orientation of the gaze of the individual. And almost like the head righting reflex. Caution when applying Freyettes Laws for assessment and treatment of the thoracic and lumbar spine is warranted. And so, again, I think it's important to understand what the literature tells us, understand that coupled motions exist, and then also not hang our hat or be stuck into, okay, these are laws, these are hold for each individual, and they also hold for each region in the spine, because that's not what we're seeing. Okay, if you'd like to learn more about the coupled motions or the arthokinematics, these are the resources that I have found incredibly helpful, and I've cited a lot of them within the couple slides that I've already presented. Okay, coming back to our outline, we're going to move on to the kinematics and the kinetics of high velocity, low amplitude thrusts. We'll talk about the cervical spine, the vertebral artery strain, thoracic spine, lumbar spine, and the segmental movements. Okay, so let's first talk about high velocity thrusts and kinematics and kinetics, definitions and phases. Okay, so starting off with some operational definitions for consistency and clarity. Thrust speed, speed of delivery of the thrust immediately before cavitation, expressed as time to peak force. Peak force, maximal force exerted to the joint. This can be done directly as far as like the amount of contact of the hand against the spine and or against the mounted table sensors. Thrust duration, usually measured at the time from the dip, and we'll talk about what the dip is, the instant to the time of peak force. Okay, so preload is the quasi-static load applied to the soft tissue overlying the segment to be manipulated. The purpose is to compress the soft tissue and move the joint toward the limit of physiological end range. Doing so, this can also increase the patient comfort during the procedure. The amount of preload may be adjusted voluntarily based on the afferent feedback from the skin and muscle sensory organs of the treatment arm, i.e. based upon what the sensory input that you're feeling within the tissue. This may determine how much preload you use for one patient versus the next, one joint versus the next, even if it's within the same patient. Downward incisional point, or the dip, which was alluded to in the last slide. This is the diminution of the preload force just before the thrust. So it's essentially your derotation, you're backing off of the initial preload that you put onto the joint. It's commonly termed the run-up or coming off the barrier when used in the teaching environment. And so we'll when we talk about the derotation or coming off the barrier, we're talking about this dip. Okay, so an example is of each of these points are shown here. So what you're looking at is on the y-axis force or percent of peak, and on the x-axis you're looking at time, and you're looking at the kinematics of a thrust. So if we play out the animation, right, when you get to 1, that's going to be your preload. Then your dip, you're going to back off the barrier. That's going to be your speed and your thrust, the peak force. And then your duration of thrust is going to be that time from the dip to the peak force at the top. Moving on to the cervical spine specifically. So here's an example of the cervical spine thrust, as well as how this correlates to the preload, the dip, the peak force, the speed, as well as the duration of the thrust. So preload, backs off, thrusts, and off. So very quick. Okay, so this information may be quite granular, but it's been helpful for me when I've been learning this material, and I'm hoping it's going to be helpful for you as well. So orienting you to this table, you'll see that we're talking about the different spinal regions: upper cervical, mid cervical, and then lower cervical, or the junction, and the number of cavitations that you can expect. So regardless of what segments of the cervical spine we're discussing, you can expect more than 2 cavitations, a bit more at both of the upper cervical spine and at the junction. The cavitations, as far as being unilateral or bilateral, we can see that consistently, at least for the upper cervical spine, that bilateral cavitations are expected in over 90% of thrusts. It's a bit different when we're talking about the cavitations at the mid-cervical and the lower cervical, which potentially are going to be unilateral cavitations. What is not specified is whether it's ipsilateral or contralateral cavitations, but rather that the cavitations are occurring on a single side. And then you can see what I've denoted there with the symbols. So cavitation was no more likely to occur on the ipsilateral than the contralateral side, and this pertains to the unilateral cavitation for the upper cervical spine. And then if you're going to manip the upper cervical spine, there's 11.3 times more likely occurrence of bilateral rather than unilateral cavitations. And however, it's almost the opposite if you're going to do the CT junction manip, that 10.5 times more likely to occur on the opposite side of the short lever. And we'll talk about the short lever and with the setup and where that 10 times more likely side of cavitation is to occur. Okay. A bit of a full slide here, but we'll step through it together. So you're just seeing the different studies that have considered the pre-thrust positioning for the cervical spine. So I want to focus your attention not so much to all the numbers, but rather to the summary ranges that are in bold on the bottom row. So we see that rotation within the cervical spine would be between 30 and 50 degrees. The flexion is highly variable depending on I would say the technique and potentially even the level. And we'll talk about whether there's necessity in flexing or not the cervical spine. And then when we're looking at side bending, again, there's quite amount of variability between 6 and 30 degrees of side bending. I think that this is going to be dependent on the technique that is being used and what your primary lever is, such as, is your primary lever going to be side bending to take up the joint slack and then more of a rotary thrust, or are you going to combine that side bending and that side thrust in combination with a rotary thrust? And that would really kind of determine how much side bending the neck is in prior to the thrust. All right, when we're talking about the derotation, this is specifically, in other words, our dip. Then there's going to be about a 5-degree coming off of the barrier. It is important to note this is only noted in one study and by one research group, and so there is a range here, even within that same study, that it can be up to 16 degrees that you come off the barrier, and then there can be almost minimal, depending on the thrust technique and maybe even the provider / the patient's arthokinematics and neck that you're working on. The amplitude, so the amplitude of the thrust and how much displacement there may be, depending on whether this be rotary, side bend, etc., that this can be between 11 and 46 degrees. So when we, I do want to state that you can see the asterisks next to amplitude, which denotes that all of these studies looked at rotary thrusts of the cervical spine. And so you can say that there would be between 11 and 46 degrees of rotary amplitude. When we're looking at the chin rotary thrust, specifically in the NIAN 2005, we're looking at the C5, C6 level inside. For the last one, Klein 2003, they were looking at C3 to C5. And then the last denotion that you see there is that the 2 degrees of flexion was associated with cavitation in 93% of the cavitations. So what Klein found was that very limited, essentially only having 2 degrees of flexion was associated with over a 90% chance of cavitation. Time of initial contact to the completion of the thrust took 7 seconds, at least in the Klein 2003 study. What that converts to is constructive fiddling or setting up of the optimal barrier and components only takes a few seconds. I would say that this is obviously within an expert clinician and someone who's quite comfortable with the technique. This likely should not be a goal when initially learning the techniques and getting comfortable with it. In fact, I encourage you to explore the different parameters and the different vectors. The more time that you have to quote unquote fiddle, likely in the early going will be helpful for your overall expertise and retention of the skill. Okay, so when we're looking at the cervical spine thrust positioning and some of the other parameters around the actual thrust itself, specifically here we're looking at mean time. So the average time is 135 milliseconds. This is comparable to physiological reaction times, and it's been shown that if sufficient speed is applied, then biomechanical effects of manipulation are completed prior to any protective muscle response that may develop. And there's been kind of a range described as far as how quickly these thrusts are being applied, and the duration of the thrust, I should say. So everything from 60 milliseconds all the way up to the upper bound would be about 200. You do have that upper range of 250 milliseconds, but the mean duration within that time frame was 158 milliseconds. And again, that 135 is about the amount of time. It may be different from one individual to the next, one patient to the next, as far as like how quickly you'll get that more reactive protective muscle response. Okay, so when we're looking in summary of the pre-thrust positioning, you have 30 to 50 degrees of rotation, 2 to 30 degrees of flexion. Again, this may be dependent on the technique being provided, maybe even the segment, maybe even the individual and their body habitus and how much their head is off or not of the thrust surface, be it the pillow and or the table. Keep in mind that Klein 2003 study found that the less flexion that was applied, the higher percentage, specifically 93% of cavitations occurred with that. Side bending, as I mentioned, whatever your primary lever is may dictate how much side bending there is. Derotation, anywhere between 0.5 and 16 degrees with a mean of about 5. Amplitude of the thrust is going to be between 11 and 46 degrees. So derotation displacement is significantly correlated with the following: thrust displacement, thrust velocity, and peak thrust acceleration. I.e., the more derotation displacement, the more thrust displacement, velocity, and acceleration will occur with the actual thrust itself. There's also a wide range of kinematic parameters seem to be able to produce the same success with a manipulation, if success is determined by cavitation. Okay, so when we're looking at peak velocities, we can see that there's 127 degrees per second. The mean velocity is about 72 degrees per second for the cervical spine, and the mean peak acceleration is essentially how quickly is by far the most, with over 2,000 degrees per second. The duration is going to be 80 to 200 milliseconds, and the amplitude, again, is going to be between 11 and 46 degrees. What it looks like in live time is this. So if we slow the video down, you could see that despite it being a comfortable thrust for Tiffany, it was she did wince and tighten at like right before the thrust, or like right after the thrust, which suggests that Taylor's speed here was, and the duration of the thrust was less than 135 milliseconds. Okay, taking a closer look at Klein 2003, one of the articles that we had previously mentioned. So 56 manipulations, 86% of the cases had a cavitation or were deemed successful. 50% of those needed 2 attempts. When they looked at C3 versus C5, they did not denote any 3D range of motion changes. Thus, angular displacement were not larger for C5 versus C3. Rotation and lateral flexion down to level is not necessary. Rather, it's where you put your hands in your contact that is the most important. Axial rotation and lateral side bending were positively correlated. Rotation and lateral side bending were always in the opposite direction. So the therapists or research personnel used type 1 coupling motion, which is counter to the natural type 2 coupling motions of the regions of C5 and C3. So the heterolateral coupling, or the type 1, contrasts with normal behavior of the lower cervical spine, for which homolateral coupling, type 2, is described. Though this is consistent with Freyettes' third law, as far as taking up slack or motion in one plane will limit that of another, and then also potentially creating an artificial barrier by countering the coupled motions. The conclusions of this author is that the importance of the heterolateral coupling during cervical spine HVLAT remains unclear. Okay, and here's a picture demonstrating the kinematics of the thrust, and it's a bit busy, so let me help you make sense of it. So on the y-axis you have amplitude, where you have 0 and you have positive and negative amplitude, as these may change during the thrust or the motion. And then on the x-axis you have time. So this is a typical head displacement pattern recorded during a manipulation at C5 on the left side with an audible release. The peak axial rotation and lateral side bend are indicated by that black line that you see, and you'll notice that they are inverse to one another. And then the flexion, right rotation, and right lateral side bend are positive. So I know it doesn't seem as though they're positive just because they show negative values or amplitudes here by the degrees. It is important to kind of orient these to the actual plane of the thrust. And so what you can see is that they are inverse to one another, the rotation and the lateral side bend. And then keeping in mind this image as far as like the 3 different planes of motion, because this will be relevant when we get to the lab section of the live lecture. Okay, then when talking about the mechanics of the thrust and how this correlates to the available range of motion of the cervical spine, and this will also get into our discussions as far as the safety of it in regards to the vertebral artery. So based off the previous tables presented, you can see that I've overlapped what range of motion is otherwise necessary within the cervical spine to actually go through a thrust technique if we're using the mean values from those tables. And so there's, besides for lateral flexion, there's a considerable small percentage of the available range and the natural physiological range of motion of the neck that is taken up in each of the sagittal as well as the transverse planes. So the range of motions obtained during HVLAT are well below the active range of motions reported in the literature. This is essentially the take-home point. For the cervical HVLAT, the maximal amplitude between the head and trunk does not exceed physiological active ranges of motion. Thus, is it a mid-range HVLAT or an end-range HVLAT that is being applied with the studies that we've looked at? I'd make the argument that it's likely going to be a mid-range, given the fact of the amplitudes as well as the positioning of the cervical spine with these thrusts. So do we really need to enter the paraphysiological ranges to be able to perform the cavitations? Again, I would make the argument that's not the case, is that if we know the arthokinematics and how the joints actually move, and then we're quick enough, we can create artificial barriers and use the speed to help us not go into these paraphysiological ranges. The reason why paraphysiological ranges are maybe unwarranted, one, due to patient comfort, not only within the moment but thereafter. It can leave you sore when you go beyond the paraphysiological ranges. And then also there's further question as far as the safety when you do enter those ranges, more so than the ranges the person is otherwise accessing. Amplitude of rotation, which is generally assumed to involve greater risks for negative side effects, is significantly lower during active motions. Okay, and we'll use our schematic here again to demonstrate and summarize the information that we've presented thus far in the kinematics and the kinetics of the high velocity, low amplitude thrust of the cervical spine. So here's the addition of the preload, which is about 5.6 pounds of force. The derotation about 5 degrees up to 16. Speed 72 degrees per second. The peak force is 20 pounds of force. And then the duration is 80 to 200 milliseconds. And so the take-home message, beyond giving you some guidance as far as like how much force you are actually going to be applying, not only with the preload but also with the peak force, is that in the cervical spine, less force and faster speeds are needed for effective thrust techniques. It's also important to note, if we're looking at the duration of the derotation as well as the actual thrust, is that it's about a 1-to-1 ratio. So as quickly as you come off the barrier is as quickly as you apply the thrust. All right, let's talk about the vertebral artery and the safety of these techniques. So you can break the vertebral artery up into 4 different segments. In particular, V3, you can see this on the schematic and how they align. So going from a essentially a cranial to a caudal direction, you have V4 to V3, V2, and then V1. And the area of suspicion, or highest suspicion, is this V3. And this is the portion of the vertebral artery that is potentially compromised, makes sudden directional changes, passes over bony landmarks, and is connected to the region of the cervical spine with the greatest ranges of motion, C1 and C2. All right, so in order to help guide us with safety of the vertebral artery during these techniques, we'll turn to the literature. And so this first study looks at the internal forces sustained by the vertebral artery during spinal manipulative therapy. And they quantified the strains and the forces sustained by the vertebral artery in situ during SMT. It was a cadaveric study with 6 vertebral arteries being extracted. And then you had your cephalad distal, C0, C1, and the caudal proximal C6 to subclavian artery loops of the vertebral arteries were carefully exposed and instrumented with a pair of piezoelectric ultrasonographic crystals. The strains between each crystal pair were recorded during the range of motion testing and diagnostics tests during a variety of SMT procedures. The VA was vertebral arteries were then dissected free and strained on material testing machines until mechanical failure of the vertebral arteries. So essentially they looked at how much strain was occurring with the SMT, and then also how did this compare to the max failure or mechanical failure of the vertebral arteries after they had already manipulated them. Okay, so here you can see the schematic setup of the study and of the cadavers. They provided an illustration, so you can see that the little white dots demonstrate the crystals, and that this goes all the way up to like through V4 and all the way down through V1. The measurement of strain and elongation of the vertebral artery was based upon the separation between the adjacent crystals. So as you went through, as the cadavers were taken through the manipulation, that the strain and the force was determined by how much displacement there was between one crystal and the next. Specifically, if we're looking at the V3 segment there, you can see the two arrows denoting that. Okay, so before we get to the results, it's going to be important to first consider the validity of this. What assumptions, is it safe to draw assumptions as far as like the manipulation provide to a cadaver versus a live individual? And so this schematic demonstrates the research of the same research group that looked at their manipulations and the forces applied, the speeds, etc., from normal manipulations on live individuals to that of the cadaver specimens. And you can see that the mean lines, as denoted by the red and the black lines for normal and cadaver studies respectively, shown to be quite consistent with one another. Moreover, you can see the slight variability as in the shaded regions with the slightly off color gray scale versus the slightly pink shaded there. So really what the take-home story is that yes, they are virtually identical, suggesting that the thrust treatment forces given to the patients and in our in their cadaver work are very similar. Okay, and so here are the results laid out in Table 2 and Table 3. So in Table 2, they did a summary of range of motion and VBI testing and looked at the percent of strain on the C0, C1 strain, or the V3 segment, as well as that of the lower portions of the spine. And here are the tests. So flexion, extension, ipsilateral rotation, contralateral rotation, ipsilateral side bend, contralateral side bend, and then the VBI testing. And what we can see is that the distal strain, or the percent from neutral, is the highest. When I rotate to the right, it's going to be the highest on my left at C1, C0, C1. And this is also quite close to that of the contralateral VBI testing, or vertebral. Again, VBI is vertebral basilar insufficiency screening, and we'll go through this in lab for clarity on what that is if you're not already familiar. Okay, so then how did these values compare to the summary of strains during the spinal manipulative therapy techniques? And so you can see the 7 or so 6 different techniques that were shown there, and the different strain gauges. So ipsilateral C3 through C4 break was the highest at 10.7 for the upper cervical spine, but these were all within the same ranges of normal physiological ranges of motion, particularly of the rotation and the VBI testing that were shown in Table 2. Okay, so here's a visual representation of the results. So on the y-axis you have strain, on the x-axis you have the neutral resting position, the SMT, and then the actual failure strain of the vertebral artery. So you'll note that 0 strain or 100% from neutral is shown in that first bar, and then in the second bar with the SMT techniques, that this gives you a relative idea as far as like the percentile of the total failure of the vertebral artery. And so it's only approximately 12% if you were going to do the math as far as like how much relative strain that the SMT put on the vertebral artery. And this 12%, as we saw, was comparable to that of rotation and VBI testing. Okay, so this was kind of a review paper. Their objective was to review the results of the existing studies on human vertebral artery strains during SMTs, administered by qualified clinicians, and compared them to the strains encountered during full cervical range of motion. The summarized results of unpublished works from strains measured from all sections of 8 vertebral arteries during data from 3 clinicians. And then you can see that the total number of N, or the number of strains that they captured, was well over 2,000 for both spinal manipulation as well as for the full ranges of motion. These were, once again, cadaveric studies, just given the nature of what they were looking at. 16 vertebral arteries obtained from 10 uninvolved cadavers. Okay, very similar setup and methodology to that of the previous study. There are some overlap in researchers here. So here's the details of the cadaver subjects used in this study. So you can see the ages of the individuals are shown there. This is worth consideration from the standpoint that obviously the age of the vertebral artery in question would likely be correlated with the failure, the mechanical failure force of that said vertebral artery. You can see that there's a mix of males and females. You can also see the different causes of death, and that some of these were quite pertinent to like the cardiac and the cardiovascular system. Okay, so here's a graphical representation of the results with distance of displacement on the y-axis and then time along the x-axis. So changes in the length of a V4 vertebral artery segment, given the distance between 2 crystals, are shown. You can see that the gray line, or trace, is specific to flexion and extension, cycling of the neck, and then the black trace is shown with for the thrust, or the lateral/rotation SMT therapy. And the onset and the end of the SMT is denoted by the arrows that you see there. And so you can see that the amount of displacement for the vertebral artery with flexion and the neutral positioning of the head is significantly more than that which is seen by the actual thrust itself. Additionally, depending on how quickly the individual is moving, right, you can also see the amplitude, or the slope of the thrust technique relative to the flexion movement of the head is somewhat comparable as well. Okay, so a similar research group looked at comparable strains and changes in length of the vertebral artery at different levels, C2 and C3, as well as C3 and C4, in relationship to the cervical rotation ranges of motion, as well as that of a cervical manipulation. And what you can see is that the amount of displacement or change in length of the vertebral artery for the manipulation ranges between, regardless of what segment you're looking at, is between 0.2 and 0.4 millimeters, versus that with the actual cervical rotation, that the amplitude ranges between 0.6 and as much as 1.5 for C2, C3. The conclusion that the authors came to was the peak strain elongation from neutral that was measured for any of the 176 treatment procedures was 2.1%, while strains of the diagnostic procedures were in excess of 10%. And then this suggests, in agreement with the author's previous studies, that strains during HVLA were much smaller than those produced during diagnostic procedures. So this also speaks to the questioning of some of the diagnostic procedures such as VBI and the end ranges of motion that we take our patients through, just with their active screen. But it speaks to the safety of this when the actual manipulation itself puts a 2.1% strain versus like the 10% or excess that can be seen with the active range of motion screening. So the last several studies have looked at the vertebral artery strains with not only ranges of motion, VBI testing, as well as the spinal manipulative techniques. This study now turns its attention to the internal carotid artery, still led by the same primary research group, and the lead research author being Herzog out of the University of Calgary in Canada. You can see in the illustration there to the left that the sonomicrometry crystals are now placed in the internal carotid rather than the vertebral artery as previously demonstrated. The images A, B, and C show some of the ranges of motion and positions that the cadavers were taken through. It took place on 6 fresh cadavers. The manipulations were performed by 6 experienced chiropractors. This demonstrates very similar to what we saw with the carotid or with the vertebral artery. On the y-axis, you have the length and the change of the internal carotid artery, and then on the y-axis, you have time. The gray line representing that of the ranges of motion that the necks were taken through, and then the black line representing the spinal manipulative technique and the relative strain there. Once again, you can see that the elongations of the internal carotid, like that of the vertebral artery, and associated strains are much smaller than the high-speed, low-amplitude cervical spinal manipulative techniques than they were with the range of motion testing. And thus, the conclusion was that the SMTs are less likely to produce stretch-induced damage to the internal carotid than normal everyday head and neck movements involving the full possible ranges of motion. The conclusion is that that the SMT did not appear to place undue strain on the internal carotid and thus does not seem to be a factor in ICA injuries. And they calculated the relative percent strain. So average of all maximal internal carotid strains obtained during the SMTs were about 28% of the measured during the range of motion testing, which was 10% of the ultimate failure strains of the ICA, demonstrating again just a small fraction of the overall failure threshold of the internal carotid arteries, deeming or giving confidence in the safety of the technique. So the last several studies have looked at the mechanical stress and strain of the vessels within the cervical spine during spinal manipulative therapy, as well as during ranges of motion in the VBI testing. But the other consideration is when a patient presents with either known or unknown atherosclerotic plaques within these vessels, and what is the risk of potentially rupturing the plaques and creating an emboli that would otherwise increase the risk there of stroke and or TIAs. So the study used a fluid structure interaction model to do a safety risk assessment of spinal manipulative techniques for atherosclerosis to study the biomechanical changes of the atherosclerotic plaques and the carotid artery lumen during the process of spinal manipulative techniques. And so here is a schematic demonstrating that. So on the left-hand side, you can see that you have the cross-section of the vertebral artery, and that is taken with an MRI. So it's a T1 weighted segment of a whole lipid geometry, and the artery and the lipid core, as well as the lumen of the artery. And there's different portions of a plaque that can build up. So you have the fibrous cap, the calcification, and they've used this to demonstrate the lipid core with the coloration of yellow, purple, blue, and green respectively. And then here is the restructured model. So on the left-hand side, they took an individual that had atherosclerosis within the carotid artery and the internal carotid artery. You can see right at the split there. And then they used a model to replicate this using the fluid structure interaction model. And this is shown here. Once again, you have the lipid core, the calcification cap, and the fibrous cap, the different portions of the plaque. So what the study did is they looked at mid-range versus end-range rotation manipulations and the relative stress and strain that is put not only on the vessel itself, but also on the plaque wall and the different portions of the plaque. So they cited the Herzog study that we previously looked at, where they looked at the stress and strain on the internal carotid artery during end-range manipulation as well as mid-range manipulation. And you can see the relative strain that is put on the vessel specifically with the left and right respectively, with the mid-range HVLA shown on the right being about 1/3 of the strain on the vessel compared to that on the left at the end range. Now, the significance of looking at the strain of the vessel is that with the increase, there's a linear and proportional relationship that the higher the strain on the vessel itself, the higher the strain on the plaque. And we'll get into looking at rupture thresholds in the coming slide. In order to understand the results, it's important to look at the anatomy, not only of the blood vessels, but also of the plaque. And so we noticed that the researchers within this study broke the plaque up into its different components, which really is invasive within the intima, which include the fibrous cap, the calcification, as well as the lipid layer. Here we have the cross-section of the vessel wall as well. So you have the tunica adventitia, which is the outermost layer, and then you have the tunica media, which is made up of smooth muscle and is the middle layer. And it will be important to kind of consider this as we look at the results of this study. So here's the replication of the plaque as illustrated, and you can see that there's by far, in a way, more invasive components and deformation of the intima, the media, and then respectively the adventitia. So previous studies have considered looking at the risk of plaque rupture, not only looking at each of the layers of the vessel wall, but also of the plaque wall itself. And so they've taken a mean value as far as the rupture rate of the plaque or the risk of rupture and the different thresholds of strain at the different layers, not only of the vessel, but also the plaque. So the tunica adventitia at about 1100 kilopascals, there will be potential for the rupture of the plaque. So that's the application is directly at the adventitia underlying the plaque. And then if we look at that at the tunica media, the threshold is even lower, about half or so, at 519 kilopascals, and then the plaque rupture threshold, if there were about 300 kilopascals applied directly to the plaque itself, this would lead to the potential risk for the rupturing of the plaque and thus the creation of an emboli. So keeping these values in mind, we can consider the results of the study. So here what they've looked at is they've replicated the model of the plaque, and they've looked at the plaque stresses in two different forms. So one is the plaque wall stress directly, and then the wall shear stress on the plaque. And those are shown in the top row and the bottom row respectively. And then keeping in mind that 300 kilopascals as far as the plaque rupture threshold. So we can see 2, 6, 7, 10, and 12% in each of the respective columns, and that's a percentage of the strain on the vessel itself. And then what we can see is that at each of these strains that there's a linear relationship with the maximal kilopascals that are applied to the plaque, be this a shear stress or the plaque wall stress specifically. And you can see that the kilopascals and the stress on the plaque are relatively low, regardless of whether we're looking at 2% strain on the vessel or up to 12% strain. That being said, okay, and then in the table shown here in the first column, you have the stretch on the different structures, so the fibrous capsule, the calcification, the lipid, as well as the vessel underlying the plaque. And then you have in the subsequent columns, you have the stretch on the vessel at 6, 7, 10, and 12%. And then the kilopascal values that are applied with each of these amount of stretches to the vessel. Now you'll notice that the highest values are with the calcification, but this is still sub the threshold for the risk of rupture within the calcification portion of the plaque. That being said, the values that do come close to increasing the risk of the rupture of the plaque would be that of the vessel, specifically of the media and the adventitia underlying the plaque. So you can see at 10 and 12% strain on the vessel that the kilopascals applied to the vessel wall, which would potentially lead to the risk of the rupturing of the plaque, are either at or surpasses the threshold that has otherwise been calculated at 519 kilopascals. Now, the significance of this is when we're looking at the stretch on the vessels and the spinal manipulative techniques, which techniques put this amount of stretch on the vessel that would otherwise surpass the threshold for the tunica media to increase the potential risk of rupture of the plaque. And as we recall from the previous slide, is that the end range rotational manipulation technique puts an average of 7% strain or stretch on the internal carotid artery, but it's a plus or minus of 9%. So the end range technique has as much as 16% strain on the vessel itself, whereas the mid-range manipulative technique has a maximum of approximately 6%, so half of that of the 12% stretch that would be needed to potentially meet the rupture rate of the tunica media or the vessel wall, setting the plaque off and causing it to rupture or risk of rupturing. And so the conclusion that the authors came to is that the carotid artery's higher stretch generated the higher stress levels of the plaque. As I alluded to, there's a linear relationship. The more pressure there is on the vessel, the more there is on the plaque. The cervical rotary manipulative technique, that is the end range position, the end range technique, puts the plaque at a higher risk of rupture in deformation of greater than 12%. And then the lower deformation of the plaque and artery caused by the HVLA or the mid-range technique might be a safer option. So I know we're really into the details of this, but I do think that it is really pertinent not only to consider the safety of the spinal manipulative techniques in the individual who does not have atherosclerosis or plaque buildup of their vessels as previously seen in the studies that we looked at initially, but then also considering what is the safety of the types of techniques that would be using should there be a known or unknown atherosclerotic plaque buildup within the internal carotid and or the carotid arteries, and knowing that the threshold for the the vessel wall is lower in the atherosclerotic vessel, an individual, than it would be in the healthy vessel. All right, moving on now to the thoracic. Okay, so the number of distinct cavitations that we can get from a thoracic spine thrust is anywhere between 2 and 6. 82% of your thrust techniques should equate to multiple cavitations. The distance from the said target level can be anywhere between 3.5 and as much as 9.5 centimeters. And then the skin fascial interface, or the displacement of that, this is most pertinent with your prone techniques, will be between 3 and 4 centimeters. When only or less than 2 cavitations occur, less likelihood to cavitate at the target segment. When greater than 4 cavitations occurred, there is a significantly higher likelihood that the cavitation will occur at said target level. So your goal then would be if you were trying to be as specific as you wanted to the patient's symptoms or the target level, then you want to attempt to achieve 4 cavitations or more. 54% of the thoracic spine cavitations were deemed to be accurate, and accurate was defined by less than 3.5 centimeters of the upper cervical spine and less than 4.5 centimeters in the lower thoracic spine. And this was determined by the height of the vertebral bodies. Thoracic spine HVLAT segment level cavitation error is significantly less than during lumbar manipulations. And then the skin fascial interface has negligible friction. You must take up approximately 3 centimeters of skin fascial slack prior to the thrust of the thoracic spine, specifically within the prone position, as I mentioned. Okay, so the beneficial effects of spinal manipulative therapy or thrust may be associated with a generalized non-specific force in the vicinity of the target segment rather than a well-defined force applied to a precise target. And this is the conclusion of Ross 2004, and they drew up the schematic that kind of helps us to visualize this. So the small triangle denotes the target segment or level, and then that's also where the small applicator or the hand was placed during the thrust technique. And then the black, small black squares demonstrate the different cavitations, and you can see that though there was a couple quite precise to the target level, that there was also 2 that occurred well above, several segments above there, and then also several segments below that in several centimeters, almost 4 below and then almost 6 above. So with the thrust application, the thrust vector is perpendicular to the axis of the target segment. So a force at a 45-degree angle to the spine will reduce the magnitude of the thrust by approximately 70%, which is significant. This may make the difference between a cavitation and no cavitation. The duration of the thrust is a little bit longer than that of the cervical spine. It's 120 to 200 milliseconds, whereas the cervical spine, as we saw, could be as quick as 60 milliseconds. The preload force is comparable to the actual force applied within the cervical spine with 26 pounds of force. And then the peak force with the thoracic spine thrust is significantly higher at 111 pounds with a range of 53 to 141. The peak thrusting force is closely associated with the amount of preload force. So thus, the more preload force that you apply, there's going to be a strong association that you're going to put on a proportionate amount of peak force. A stiff joint requires both more preload and peak thrusting force compared to a said quote-unquote soft joint. So the stiffer someone may be, the more preload force that you would use, and thus the more peak force that you would also apply. So with the thrust application, the thrust vector is perpendicular to the axis of the target segment. So a force at a 45-degree angle to the spine will reduce the magnitude of the thrust by approximately 70%, which is significant. This may make the difference between a cavitation and no cavitation. The duration of the thrust is a little bit longer than that of the cervical spine. It's 120 to 200 milliseconds, whereas the cervical spine, as we saw, could be as quick as 60 milliseconds. The preload force is comparable to the actual force applied within the cervical spine with 26 pounds of force. And then the peak force with the thoracic spine thrust is significantly higher at 111 pounds with a range of 53 to 141. The peak thrusting force is closely associated with the amount of preload force. So thus, the more preload force that you apply, there's going to be a strong association that you're going to put on a proportionate amount of peak force. A stiff joint requires both more preload and peak thrusting force compared to a said quote-unquote soft joint. So the stiffer someone may be, the more preload force that you would use, and thus the more peak force that you would also apply. Okay, and here's what a thoracic spine thrust may look like.
Yes, you do.
Oh, you got a good point there. Yeah. Thank you.
Yeah. Are you okay?
Yeah, I'm good.
Oh my God, that was it. That felt glorious.
Okay, and then onto the lumbar spine. Oh, okay, so similar to the other spinal segments and regions that we looked at, you have a table here. When we're looking at the L5S1 thrust technique, you can see that the number of cavitations can range anywhere between 2 and 9, with an average, depending on the study, 1.4 versus 5. And the milliseconds of the duration of the cavitation occurs over less than 3 milliseconds. The unilateral cavitation of the L5S1 is 93% in one study and 40% in another, so quite a spread. And this likely is secondary to maybe the different techniques that were applied, the different therapists that were applying the thrust, and the different patients that were receiving the thrust. And so with the study that denoted 40%, you can see that there's relatively good, almost even split as far as like which side cavitated, be it the upside or the downside. And then the bilateral cavitation is expected to occur in 60% of your thrust, or more than half. And then the distance from the target segment is a bit more than that of the thoracic spine, and certainly more than that that we saw in the cervical spine, with almost 5 centimeters of displacement. However, you can see the range there is quite significant, as much as up to 14 centimeters from the target segment. Cavitations are 1.5 times more likely to occur bilaterally than they are unilaterally. And specifically for the 5.29 centimeters displacement, greater than one segment above or below the target segment. That's what 5.29 centimeters equated to within these subjects. With an L5S1 and an SIJ HVLAT, there is no statistical correlation between the anatomical level of the cavitation sound and the adjustment technique selected. So that's important to keep in mind. Okay, and then this graph here, you can see on the y-axis is the number of cavitations, and then on the x-axis you have the different segment levels and the number of cavitations that occurred at said level. All of these thrust techniques, you can see, were applied to either the L5S1 or to the PSIS, i.e. the SIJ HVLA technique. And so I implanted the small triangles there so you can see where the level at which the thrust was applied, the target segment, and then you can see relative to the same color coding of the histogram where the majority of the cavitations occurred. So taking the L5 pole technique, for instance, we can see that the L3, L4 upside facet cavitated more often than the L5 S1 facets. Even if you combine both the left and the right facet, then it was the L3, L4, 5 facet was still significantly more, specifically on the upside. And then same for the SIJ, HVLAT, the cavitation was most often at the L5, S1 upside facet rather than at the SIJ itself. Results indicate that the two different methods of manipulation did not produce cavitations at significantly different locations. There's relatively equal distributions when you run the statistics on this. Okay, and then when we're talking about preload, duration, peak force, and thrust rate, we can see about 27 pounds of preload, so slightly more than that of the thoracic spine and well over that of the peak force that we saw in the cervical spine. Duration of thrust is comparable to what we saw previously with 139 to 150 milliseconds. Peak force less than that applied within the thoracic spine, but you can see that the range here is quite variable from anywhere from 47 to 153 pounds of force. And then the amount of pounds per millisecond are shown there. So do your segments actually move? So a couple studies have considered this. So Gal, 1994, in the thoracic spine, used a high-speed cinematography, 100 hertz, in both sagittal and transverse planes to record movements of the bone pins that were threaded into T10, T11, and T12 during spinal thrust manipulation. Obviously, this is a cadaver study. And then the Main 2000 in the lumbar used a 5-gram damped accelerometers with a bandwidth of 5% from 0 to 60 hertz and a resonance frequency greater than 250 hertz. And so this is for those of the audience who are quite familiar with the instrumentation of accelerometry and being able to discern the importance or the significance of this. The accelerometers were fixed to metal supports that were rigidly mounted to the vertebra, and again, both studies were obviously cadavers. Okay, so there's a picture of the cadaver or the dead body that they're manipulating, right? And then so you have the view through the sagittal plane camera, and you can see how it was set up with the bone pin sticking out of the top, and then the accelerometer, and then the surface marker is shown at the adjacent levels. Okay, and so what did they find? So segmental motion. So within the thoracic spine, they moved 6 to 12 millimeters anteriorly and 36 millimeters or 3.6 centimeters into left lateral translation. Axial rotation and sagittal plane rotation were minimal. You can see the thrust force were quite a range, but comparable to previous values that we've seen. The L4 and L5 moved towards each other during the rise in pressure and moved apart or separated at the pressure decrease. This is consistent with the mechanism and phenomenon that was discussed in some of the earlier parts of the pre-lecture material, where you get a gapping of the facets or separation of the vertebral bodies. Maximal volume of the vertebral approximation between the beginning and the end of the thrust was 1.1 millimeters. Okay, and now we're on to the conclusion and references. All right, and with the conclusion, I'll leave you with a couple of summary points and resources. Okay, and for those who are really interested and fascinated in the physics and the kinematics of high velocity, low amplitude thrusts, here are some additional resources that you can look up. Again, I have used some of these resources within the information already presented, but they do go into much further depth. Additionally, the arthokinematics and additional introductions in further detail on a lot of the information that is presented today can be found in these 4 resources. Gibbons and Tejan, Herzog, Donald Newman, and Gregory Maitland's texts serve as a comprehensive means of really honing these, the explicit knowledge of these skills. Okay. Additionally, further courses that I would recommend are the Spinal Manipulative Institute. They have a certification course. This is quite rigorous in nature. I've heard it's even a little bit more challenging than the OCS from those that have taken it. It involves 4 courses, and then there's actually, in the 4th course, the certification course, is a written as well as a practical examination. Gibbons and Tejan spinal manipulation courses, and then also MedBridge has a couple of Gibbons and Tejan's additional courses, and then I believe there's other practitioners on there that have courses on spinal manipulation and high velocity, low amplitude thrusts, not only for the periphery, but also for the spinal manipulation. Okay, thank you all so much for listening. Please feel free to leave your comments, questions, concerns, and feedback in the sections below, or contact one of us, that is to say myself, Taylor, or Lauren directly. We'd be happy to answer and provide further detail when and where appropriate. Okay, and the references for all 3 parts of the pre-lecture material and the actual lecture can be found here. Okay, and the references for all 3 parts of the pre-lecture material and the actual lecture can be found here.